free paper round of this historic midterm All India Conference 2023. So maybe we can start with the presentations. The first speaker, Dr. Anup.
Since 1 month, insults in onset and gradually progressive and associated with the floaters. The patient also gives a history of trauma to of vision, and patient did not consult any ophthalmologist. There is no history of pain, redness or flashes. Past history was nothing significant. The patient was nil systemic. Family history is also nothing significant. Then moving on to the ocular examination, head posture, ocular posture, everything was normal, and even the anti-segment was normal in both the eyes. So moving on to the fundus picture, on distant direct ophthalmoscopy, the glow was seen in both the eyes. On indirect ophthalmoscopy and 90D slit lamp biomicroscopy, the media was clear in the right eye. The disc appears to be normal in size and orange in pink with well-defined margins. The cup disc ratio was vertically 0.65, horizontally 0.5. NRI was healthy and ISNT was followed. The vessels A to B is equal to 2:3, and the macula foveal reflex was present. In the peripheral retina, grayish elevated spherical lesion present superior-temporally, measuring around 3 disc diopter and 2 disc diopter away from the superior-temporal arcade. The left eye fundus was absolutely normal. The fundus picture is as follows. In the second picture, you can see the retinal cyst in the superior-temporal quadrant. The management, then moving on to the investigations, all the routine blood investigations were done. Fundus photography, B-scan ultrasonography was done. Fundus photography also shows the retinal cyst as seen in the picture. On doing the B-scan ultrasonography, we could also see the retinal detachment in the same area. The final diagnosis was accounted to be in the right eye retinal cyst with subtotal retinal detachment with macula on in phakic eye. The left eye was within normal limits. Then moving on to the treatment, the 240 band buckle with 3 ports pars plana vitrectomy with membrane peeling with fluid air exchange with endolaser and silicone oil infusion was done. Moving on to the discussion part, blunt eye traumas comprise all closed globe injuries in which the mechanical deformation and or direct energy delivery causes the tissue damage. The retinal sequelae of blunt traumas span a variety of well-known conditions including commotion retinitis, which also called as the Berlin's edema, the choroidal rupture, retinal tears, retinal detachment, dialysis, retinal cyst, and macula hole. The different types of cysts may develop in the peripheral retina, and a classification scheme has been proposed according to the size as follows. Small, which are called as 1 mm of the papillary disc area, medium 8 to 10 papillary disc diameters, and the large occupying 25% of the fundus. The medium-sized cyst, also known as the macrocyst, occurs as a result of chronic retinal detachment. These cysts are not normally associated with the retinal holes and tend to resolve completely after surgical repair of the detachment. Moving on to the conclusion, as in the case report presented, the patient had absolutely no complaints with respect to vision or any ocular symptoms following the trauma. So the late complications should be foreseen. The regular follow-up of the patient with trauma is the need of the hour, which results in prompt diagnosis and management of the possible complications.
Thank you, Doctor. Thank you, Dr. Anup. Why do you say it's a retinal cyst and not a retinoschisis?
Sir, even the OCT was done, sir. Like there was no splitting between the layers of this one. So between the layers of the retina. On B-scan ultrasonography, like we could see the perfect retinal detachment in that area, sir.
How frequently do you find these retinal cysts without a break post-trauma?
Sir, as I referred some papers, it was like they said most of the retinal cysts occurring secondary trauma will not have any breaks like that.
Is there any other surgical way of managing these patients?
So, ma'am, like we could also have tried the scleral buckle and the external like tamponade. for the above patient because as he was a young age and phakic.
But that's still the most important indication, right? Young age and
Young age and
you can
phakic, ma'am.
still
Yes,
do.
ma'am.
Do you have to address the cysts, or do they generally all cases resolve just with the management of retinal detachment?
All cases will resolve with the retinal detachment, ma'am. According to the paper also, I quoted one reference as well, ma'am. They said the same thing.
Just one, but you'll have to read
Yeah, ma'am.
more for that.
Yes, ma'am.
Okay, thank you. Next, please.
Thank you, ma'am.
Pragati? Jyotsna Sharma? No. Pratyush? Pratyush is here, right? Yeah, please come forward.
इसके ऊपर रख दो. बैटरी है. नहीं, लैपटॉप तो बंद नहीं होना चाहिए. अभी तो है. ऑफ हो गया लैपटॉप. नहीं ऑफ नहीं होगा. चार्ज है पूरा. ये 90% चार्ज है. हाँ आया. ठीक. हाँ मैं कर दे रहा हूँ. हेलो. Shall I start? Good afternoon, everyone. My name is Dr. Pratyush. I'll be presenting a paper on macular vascular density changes following cataract surgery in diabetic patients compared to that of the non-diabetics using OCT angiography. So as we all know, diabetes is one of the most widespread disease causing cataract and diabetic retinopathy. Cataract surgery, in one hand, can improve the vision, but on the other hand, can accelerate the progression of diabetic retinopathy with macular edema. OCT angiography is a non-invasive vascular imaging technique that detects the microvascular modifications early in diabetic retinopathy. In this study, OCT angiography was used to record the changes in macular thickness, superficial and deep capillary plexus, foveal avascular zone in diabetics and non-diabetics before and after the cataract surgery. So we compared and assessed the OCT angiography parameters in between two groups. The first group were the patients, diabetic patients ranging from no diabetic retinopathy to moderate NPDR, and the second group was non-diabetic patients, both pre and post-operatively. And we also analyzed the consequences of phacoemulsification surgery on progression of DR. So all the patients which fulfilled the eligibility criteria which included the eyes with normal axial length and normal intraocular pressure were taken, and the patients with severe NPDR, PDR or macular edema, patients who have taken anti-VEGF or undergone pan-retinal photocoagulation, history of ocular trauma, surgery or any sort of media opacity were excluded in the study. The patients were then examined and allotted into two groups. The first group consisted of 40 eyes with diabetic retinopathy ranging from no diabetic retinopathy to moderate NPDR. The group B were the 40 eyes without diabetes. Baseline parameters were taken in both the groups, which included best corrected visual acuity, slit lamp examination, intraocular pressure, dilated fundus examination, macular OCT and OCT angiography measurement. All the patient underwent uncomplicated phacoemulsification surgery under similar settings. Then post-operatively, we again measured those baseline parameters on day 1, day 7, day 30 and day 90. And then we did a comparative analysis. So this is one of the, this is the macular OCT images, octa images of one of the patients in the study. We have shown the pre-operative, the post-op day 1, day 7, day 30 and day 90 images. So this is the quantitative pre-operative baseline values of the two groups, group A and group B. In this, the Spearman correlation coefficient of the best corrected visual acuity with the macular thickness, superficial capillary plexus, foveal avascular zone in the group A were found to be statistically significant. These are again the quantitative post-operative OCT angiography images values on day 1, day 7, day 30 and day 90. Now, the meaningful derivation from the previous slide. So here in the light blue we are showing the diabetic patients and the dark blue is denoting the non-diabetic group. So the macular thickness increased significantly from the pre-operative values, but the difference between the two groups on the 90th day after 3 months were not found to be statistically significant. When considering the deep capillary plexus, again the values were on a rise till day 7, then again it came back to the baseline values, and the difference between the two groups again was not found to be statistically significant. Whereas talking about the superficial capillary plexus, there was a rise in the superficial capillary plexus in the diabetic group, the light blue one, and at the end of the 90th day, at the end of the 3 months, the difference between the two groups was found to be statistically significant. So in our study we found that there was a progressive increase in the macular thickness from the baseline in both the groups. This similar study was also done by Cognitel. The superficial capillary plexus became significantly higher after 3 months, but there was no significant changes in the deep capillary plexus. Similar study was done by Yu et al., but he found that both superficial as well as deep capillary plexus after cataract surgery increased. So the conclusion of the study. Superficial capillary plexus density increases only in diabetic patients at the end of 3 months after cataract surgery, which may have a predictive effect on the progression of post-operative diabetic retinopathy. So we shouldn't be in a hurry to operate early grade cataracts in diabetic patients. And OCT angiography has indeed proven to be a valuable tool in the detection of early diabetic retinopathy changes. The limitation of my study were we had a small sample size. It was a single centered based study, and we obviously have a limited time period. I would like to acknowledge my seniors and colleagues for this study. Thank you.
Thank you, Pratyush. Few quick questions.
Yes,
You said as the density increases, the severity increases, is it?
Severity of
Diabetic retinopathy?
yes, ma'am. Diabetic.
What is that?
The superficial capillary plexus were found to have increased. So the progression, the
No, go to the next. In your go next. Go to the conclusion. Yeah. What is this?
Yes, ma'am. The
Increase
superficial capillary plexus density was found to have increased.
What happens in diabetic patients? Does the density increase or decrease?
Yes, ma'am. As compared in the previous slide, ma'am, the superficial capillary plexus.
You please go to your conclusion slide.
Yes, ma'am.
Go to the next point. Yeah. Predictive effect on the progression of
Post-operative
post-operative diabetic retinopathy. So that means you're trying to say SCP density indicates a progression of diabetic retinopathy?
Yes, ma'am. It can have a predictive value.
You should read up what actually happens in diabetic retinopathy in the SCP and the DCP. And you've also mentioned that the macular thickness also increased. How do you correlate macular thickness with SCP and DCP?
No, I have not correlated. These are the values that we have got in our OCT angiography image. In the values we have got. So we have compared the two groups, the diabetic and the non-diabetic group macular thickness.
But what is the logic? Why has the DCP density increased? You should know whether it is really density or whether it is the intervascular spaces or the rarefication. That is something. And acutely, if there are any changes, is it related to the surgical edema? Edema itself can be an artifact for changes in the vascular network
No, ma'am. Previously, we didn't take patients which were having edema. We have excluded that group of patients.
Did you follow up after 3 months also?
Yes, ma'am. Yes, sir.
So what were the results?
So this result, sir.
No, the increase in SCP density. Did it normalize? Did you intervene?
After 3 months, no, sir. This is the 90th day. 3 months. We have followed till 3 months.
And if the macular edema increases, as you said, the macular thickness also increased. Did you intervene at that point of time?
No, sir. because it was not affecting the vision as such, sir. The vision was not affected because of the
But on OCT, it was center involving macular edema.
on OCT, yes, sir. There was slight increase that we have
No, no, no.
recorded,
You
sir.
said the preoperatively,
Preoperatively, yes,
patients
sir.
who did not have macular edema, those were included in the study, right?
Yes, sir. Diabetic retinopathy, yes.
No, only the SCP is increased, but on OCT there was no features of edema.
No, sir. No, sir. Edema was not there. Even before this, we were not taking any edema patients preoperatively.
So what does the study give an implication, clinical implications?
So that this cataract phaco surgery itself is increasing the superficial capillary plexus density, which may have a predictive value in the progression of diabetic retinopathy. So we shouldn't, like, in the very early grade cataracts.
But you
if
did
the
not see any alteration in the vision. Only
Yes,
the diabetic retinopathy, you mean to say the stages were
The sta-
increasing?
Yes, microvascular changes, sir. Yes, sir.
Microvascular changes, but
Cap-
nothing more related to the vision.
Yes, sir. Because we have recorded till 30th day, so that is why, sir.
90 days.
90 days, 3 months, sir. Huh? Thank you, sir.
Thank you. I gave you the pen drive, no? pen drive दिया है ना मैंने. See, they are so. I gave them a pen drive, they don't have it. Now he's asking me, do you have a pen drive? So good afternoon, everyone. This was basically, I submitted it only because I wanted to discuss whatever cases we have seen, which we assume are related to COVID infection or COVID vaccine. Yes. Okay. So I have two papers. I'll present them one after the other. So one is the retinal sequelae of COVID-19 infection. These could be classified as infections secondary to immunosuppression that were caused by the COVID infection and its treatment, or as post-viral sequelae, or as treatment-related adverse effects from steroids and voriconazole and retinal vascular occlusions. So this was a 46-year-old male who called while he still had COVID infection with symptoms, and when he came to us, this was the picture. Vitreous was full, appeared to have fungal endophthalmitis, though micro was negative, resolved with treatment. Another was an aspergillus endophthalmitis with a cerebral lesion as well, and this was biopsy micro positive for aspergillus. Then we had a patient during COVID sent to us after he recovered with candidemia, and on routine screening, candida retinitis, which resolved with treatment. A lady who called when she had COVID, she was on steroids, which led to de novo diabetes. A common theme in the previous endogenous ENDOF also was steroid causing de novo diabetes. And COVID itself also causes immunosuppression, leading to these secondary infections. So she came to us when she recovered, and we treated her with anti-tubercular therapy, presumptively because all tests were negative. A young male whose AIDS was diagnosed during his COVID infection because of the additional immunosuppression, and a tuberculoma. Another elderly male with a choroidal abscess was referred because he was not responding to steroids, started during COVID infection, treated him with levofloxacin, and then also his toxo IgG was positive. So added Bactrim, he recovered his vision. Then we had a young man with triangular scotoma, and OCT showed corresponding area of RP disruption where there was a whitish lesion on the fundus, and superficial lesions suggestive of PAM, deeper lesion called AMN. This is a known post-viral phenomena. We had an elderly man with post-viral retinitis responded only to steroids, and another younger male responded only to ranibizumab. The macular edema component responded only to anti-VEGF, not to steroids. We had patients with voriconazole who were on voriconazole, multiple non-specific symptoms, but evaluation including perimetry was completely normal. So finally we reached the diagnosis of exclusion, which was voriconazole related symptoms. Then this happened repeatedly in these patients because they do have fungal infections and are on systemic voriconazole for those. We had CRAO as part of mucormycosis, not otherwise. And again, most of these patients were de novo diabetics because of steroid during COVID. And then we had one patient with CRVO following a few weeks following his COVID infection. And again, he needed an anti-VEGF for resolution of edema. Steroids alone was not good enough, steroids and anticoagulants. Thank you. Okay. Okay. Yeah, we can discuss this.
Nice case series, madam. But the initial few cases which you said, endogenous endophthalmitis and choroidal abscess. So was it, you think that it's the sequelae of the COVID infection, or because majority of them you see now, either they have had subclinical infection of the COVID, or so when we give
Dr.
IgG,
Joshi,
IgM, they will be positive. So how do we really attribute the?
Yes. So that's why when I was presenting the case, the first endogenous end of 40s male, otherwise systemically healthy, he called me while he still had COVID because he was my prior patient for diabetes and for some reason. So he called me saying that I'm having a red eye, and it was a video call. I could see the hypopion, and he still had COVID. He was on steroids for COVID. So it has started during COVID. He has no other disease. Diabetes started during COVID.
So it could be because of steroids, you say?
Yeah. What I'm saying is immunosuppression caused by COVID as well as steroids, as well as they were getting all these tolicizumab or whatever those are. Those are all immunosuppression. So this gentleman started during COVID. The second one also had a cerebral infection during COVID and endogenous endoph as he was recovering from the COVID. And then we found aspergillus in the eye. So the cerebral infection was treated as aspergillus and he recovered. So these are starting during COVID. The lady with tubercular abscess called me again. She was my old patient from Madhya Pradesh. She called me during COVID that I can't see well with my left eye. Then I said, okay, when you recover, you come. Again, she had been on steroids at that time. So they are starting during COVID itself. And then we gave her ATT. So, I mean, then see, initially I did not attribute it to COVID. But the problem is when they come one after the other and the history is same, you have to make a link. That's how it started. It was not, it was retrospectively realized that we are dealing with COVID-related problem.
And all are IgM confirmed?
No. In fact, TB was negative, tests were negative. Toxo Ig in one patient who has a choroidal abscess. I don't attribute it to toxo at all because IgM was negative, only G was positive. So we just treated him non-specifically with levofloxacin, and because IgG came positive, added Bactrim, but he responded. Whereas he was not responding to steroids when the referring doctor had sent me after trying steroids. So it was some infection which responded to levoflox and maybe Bactrim. So I'm not saying it's toxo because toxo doesn't cause choroidal abscess actually. It causes primarily retinitis. Lot of secondary infections are documented, especially fungal, systemic, lots like osteomyelitis, spine infections. Ocular, not TB, but lot of fungal infections have been documented. Like subsequently, our cases were the first ones, but subsequently there have been cases of candida and fungal. Endogenous endophthalmitis has been rampant after that, reported. I'm sure Chaitra has also seen. Lot of endogenous endoph. Now, in fact, it's considered commonplace to have endogenous endoph post-COVID. Yeah, I'm sorry. Okay, so again, this again we started seeing patients and then realized they were related. Retinal sequelae of COVID-19 vaccination. Sorry, because of conversion to PowerPoint, it has lost its alignment. But these can be classified as vascular occlusions in the young who have no other disposing factors, inflammations, macular CNVM, either de novo or worsening of pre-existing lesions, and neurophthalmic manifestations seen in the posterior segment. So vascular occlusions, this was a young lady, 38-year-old retina surgeon actually. She came with CRVO and inferotemporal BRAO 3 days after her Covishield vaccine, second dose. And we gave her oral steroids and anticoagulants. The physician saw her because physicians see a lot of these complications post-vaccine. So they treated her and she improved remarkably. Then we had a young male, 28-year-old male. Within 11 days of his Sputnik vaccine, he came with vision drop, and this was a superior hemiretinal vein occlusion. Again, physician gave steroids, anticoagulants. He improved but required an anti-VEGF for macular edema resolution. Then we had a young male, again no comorbidities, with CRAO within 7 days of a second dose of Covishield. Probably it's an ophthalmic artery occlusion because he was no PL and he did not improve even. No other comorbidities. Then we had several cases of inflammation, anterior uveitis and retinal vasculitis, optic neuritis, several cases. So this was the first case we saw of a multifocal bilateral choroiditis in a ENT surgeon. Post-vaccine, within 3 days or 4 days, he started developing ocular symptoms. And he resolved with steroids and azathioprine, long-term Azoran. Then this was again a young lady coming within 6 weeks of the vaccine with floaters, retinal vasculitis. Again, she's on long-term azathioprine, and she has resolved. This was a young man who realized his disease a little late. He came when he was already having proliferative retinopathy with vitreous hemorrhage. Again, he's on steroids, azathioprine, and improving with aflibercept injections. And he's on laser as well. And we did his COVID antibodies, which were strongly positive. We had patients who were stable on anti-VEGF. You see this gentleman, no symptoms. We were treating him for 2 years with 3 monthly aflibercept, no complaints, just coming, taking and going. He came to us suddenly with the first time he was symptomatic, 3 days, and he had taken a Covishield 4 days back. And first time we saw fluid in his eye with a large RP detachment. And now we had to continuously give him very closely spaced injections. But despite that, you see 8 months later also there is fluid at which was never the case earlier. This was a young lady. Within 10 days of her vaccine, she came with hemorrhagic CNVM, resolved with aflibercept. This was now this male, elderly male, came with optic neuritis, which was already old case by the time he came to us. But he started post-vaccine, already into optic atrophy by the time he has come. Now this is not the gender and age for the first event of optic neuritis. Similarly, not the gender and age for idiopathic intracranial hypertension. I have never seen in this type of profile. But within 6 weeks of vaccine, he had come with severe headache, papilledema bilateral. And same for a young lady, IIH within days of vaccine. Thank you.
How many of these patients had proven COVID at any in their past history?
These vaccine patients did not have COVID. They only had vaccine. I mean, I don't think so, at least. Maybe some AMD patients, in between, they were also getting COVID infection, getting vaccinated. So that was a combination of problems.
But can it not be that COVID itself has caused a worsening of the disease?
They had, yeah, so apart from AMD, nobody else had. Like the vascular occlusions did not have COVID infection. The young people which I showed. Inflammations also, no history, no known history. Well, the ENT surgeon had massive fever immediately post first vaccine dose. He had fever, malaise. Post second dose of vaccine Covishield, it was much more severe systemic malaise and myalgia and ocular. But apart from that, nobody else had systemic features.
Do you have any hypothesis on why this is happening?
Yeah, This is known. I don't need to hypothesize. It's already known that vaccine and infection both cause thromboembolic phenomena by causing inflammation in the vessels and damaging the endothelium. So they are known to cause. There are a lot of infarcts in the brain. They have heart, myocardial infarctions. These are known. Post-infection and post-vaccine, both. So it's the same thing we are seeing in the eyes. As regards inflammation, any vaccine can cause inflammation. It can trigger. Yes, exactly. It's known to trigger VKH-like picture or any other autoimmune disease in the body, arthritis. So we are seeing uveitis. And uveitis is known post any vaccine actually. See, earliest we were seeing 3 days to 4 days, many of these cases, 3 to 4 days post-vaccine. And yeah, of course, yes. Because we had to do it to prevent a new event in these patients, young patients. We have to investigate to be able to protect them from other problems. And in fact, in the post-Sputnik patient, his antibody titer was 3000, whereas required post-vaccine titer is generally above 50 only. He had 3000. I put it on the slide. Yeah, but I'm talking of Sputnik also here. And we had post all these vaccines. It was not even partial to any vaccine. We had post Covaxin, Covishield and Sputnik. Thank you.
Excuse me. ये पीपीटी देखिए, पीपीटी में पेन ड्राइव में है, मैंने लगा दीजिए। हाँ, अदरवाइज डॉक्टर सुमित के नाम से सेव्ड होगा उसमें। वायरस है इसमें, जो ओपन नहीं होगा। क्या कौन सा? हाँ, वो सेकंड वाला स्लाइड उसमें आ रहा है। Good afternoon to all. At the outset, I would like to thank AIOS and good afternoon to all. At the outset, I would like to thank AIOC and BOS for providing me the opportunity to present my paper here. I don't have any financial disclosures, and my topic for presentation today is short posterior ciliary arteries distribution in normal eyes. So as we all know, the choroid is the most vascular layer of the eye, and apart from the choroid, it also supplies the outer layers of the retina. So any alteration or loss of the choroidal vasculature is also implicated in the pathogenesis of multiple chorioretinal diseases. SPCA are branches from ophthalmic artery. They pierce the choroid at the choroidoscleral interface, and they further branch into multiple smaller choroidal vessels. In this paper, we report the distribution pattern of SPCA in healthy eyes using SSOCT scans. So this is just a snapshot of our previous work in which we reported and validated the algorithm which is used in the current paper. So on the left side, we see that there is a OCT volume scan. From there, the software could detect the choroidal inner boundary and the choroid outer boundary. Subsequently, flattening of choroidal outer boundary was done. And with that, we could obtain the scleral en-face images just below the flattened choroidal outer boundary. So the present study was a cross-sectional study. We obtained volume scan 12 cross 12 mm, and it contained the 1024 cross-sectional SSOCT scans, and this was captured on Plex Elite 9000. Subsequently, the en-face scans were derived and using the sclerochoroidal interface at the site of SPCA entry, we manually identified the SPCA using the ImageJ software. So this is just a representative image. On the left side, we can see the total analyzed area. So the whole analysis covered an area of 144 millimeters square. Just for the sake of analysis, we also subdivided the area into 9 sectors. So we had 9 sectors like nasal, superior, central and inferior. like that we had foveal as well as temporal. So coming to the results, we analyzed a total of 68 eyes, and the age ranged from 19 to 89 years with a mean age of 58 years. BCVA was 2025 to 2020. Axial length was also within normal range, 24.2, and subfoveal choroidal thickness was 231.7 microns. What we noted was that the mean number of SPCA vessels was 2.64 with a standard deviation of 1.17, and the range was from 1 to 7. A point to note was that the majority of the eyes, that is 1/3 of the eyes, had only 2 SPCAs, and another 1/3 had 3 SPCAs. This is a slide in which we can see the on-face image. In the temporal central sector, we can see that the SPCA entry site is seen clearly with the yellow arrow, and on the right side we see the magnified image which shows the site of the SPCA entry. Also a point to note that not all hyporeflective areas had SPCA entry sites, as we can see here in the lower OCT scan as well as on the magnified image on the right side. The table above shows the distribution pattern of the SPCA vessels. It's clearly seen that the nasal central side, that is near the peripapillary area, and the foveal central, that is the area which covers the fovea, had the majority of the SPCA vessels. So overall, the foveal area, that is the foveal superior, central and the inferior, had around half of the total SPCA which we could identify through the algorithm. Statistically, we also noted that there was a weak positive correlation between the age and the number of SPCA vessels. The R square was 0.21, which explained that the 21% of the variability in SPCA quantification was adjustable. So discussion, we could see that the higher number of SPCA was seen in the elderly population, which is more than 70 years, as compared to the younger cohort, that is less than 40 or 40 to 70 years. We hypothesized that the increased detection rate could be related to the thinner choroid or better IR penetration of the OCT rays. Another point to note was that more than 2/3 of the eyes had only 2 or 3 SPCAs in whole of the 144 millimeter scanned area. This appears lesser when compared to the histological studies done in the postmortem eyes by Haire et al., wherein they showed 10 to 20 SPCAs in normal population. What we also missed could have been the medial PCA branches which are located nasal to the optic disc. So just to conclude, our validated algorithm helped to visualize the SPCA over the posterior pole, including some portion of the peripapillary area, and the foveal central as well as the nasal central area had the maximum concentration of SPCA, which correlates well with the vascular pattern of the fovea, in which the fovea derives the maximum blood supply from the choroid. Thank you for your time.
Okay, thank you. Is there any clinical significance for this finding?
This is just a study for the normal eyes. What we want to highlight that in pachychoroid eyes, if the number of SPCA vessels are larger, then there is an increased propensity to develop PCV or CSR like that. Similarly, in AMD, if we have number of SPCA vessels which are lesser, that also could explain the pathophysiology.
Okay, second, is it the distribution of SPCAs that you correlate, or is it a detection of the SPCAs? Because you yourself in your presentation said as the age advances, the number of SPCAs were more.
Yes, so what we tried to get is through the limited OCT penetration as we have with the SS OCTs now, we could get the number which is far lesser compared to the histopathology. So our detection rate compared to the histopathology is far, far poorer. So maybe with the improved imaging modalities, we can have much more SPCAs which can be visualized.
Mamta, can you start connecting your laptop? I have one question for
Yeah,
you.
please.
You can move out so that she can connect her laptop. You spoke about you detecting a smaller number compared to Haire study. How did Haire do it, and why do you think yours is much lesser compared to?
Haire's was in postmortem eyes, like once the patient dies, then all histopathological fixation and all. Ours was imaging based. I think with the limited penetration of the OCT, that's how the aging wise also the phenomenon is explained. That once the patient ages, the higher detection of SPCA is possible, because we expect that the number of SPCA should be constant throughout the age. So I think it's related to detection rather than the actual number of the SPCAs.
No, but then if you're saying you're using Plex Elite, which is one of the highest devices that we have now, how do you think, in what way can you improve visibility of the SPC?
We tried to get the flattening of the choroid outer boundary as well, and we took the scans and we did it manually, but still still I think maybe nasal to the optic disc, the medial PCA also is getting missed. Apart from that, some of the SPCAs is like visual correlation. So I think that could be the reason.
Okay. Thank you. We'll go to Dr. Mamta, please.
Excuse. It is 14 seconds. 14 seconds it started. Oh. Good afternoon everyone. Today I'll be presenting a paper on study of visual outcome in post-surgical endophthalmitis patients at tertiary eye care hospital. Yes. Hello. Study of visual outcome in post-surgical endophthalmitis patients at tertiary eye care hospital. No financial disclosure. Endophthalmitis is inflammation of inner layers of eye with exudation in vitreous cavity resulting from intraocular colonization by microorganisms. It can be exogenous and endogenous. It can occur after any ophthalmic procedure. Hence, early diagnosis and prompt treatment with appropriate antimicrobial therapy and surgical intervention are mandatory for optimal visual outcome. Aim is to evaluate the visual outcome in patients with postoperative endophthalmitis. It is a hospital-based prospective interventional study of 38 patients for a period of 18 months in tertiary eye care hospital. Patients with post-surgical endophthalmitis were included. Patients with history of trauma, history of intraocular foreign body, and who are followed up for less than 1 month were excluded. Detailed clinical history, ophthalmic evaluation was done. B-scan ultrasound of operated eye, vitreous tap was taken and sent for culture sensitivity, managed with vitrectomy and intravitreal antibiotics. In case of positive fungal culture, intravitreal voriconazole was administered. Case-by-case basis management was done. Simultaneously, systemic antibiotics, topical fortified antibiotics, systemic steroids were given after ruling out diabetes, hypertension, and fungal endophthalmitis. In case of improvement, repeat intravitreal antibiotics were given in selected patients at an interval of 72 hours up to maximum of 3 doses. Then followed up for 3 months and final visual outcome was recorded. It was categorized as poor, borderline, good, borderline, and poor. Good is 6/6 to 6/18. Borderline is 6/18 to 6/60. Poor is less than 6/60. Results, majority of patients were seen in between 51 to 60 years age group. There was a slight preponderance in incidence in males compared to females. Among various types, 71% were following SICS surgery, 21.1% following phacoemulsification, 2.6% following intravitreal injection ranibizumab, 2.6% following DSEC, 2.6% following TKP. Mode of presentation, 76.3% presented acute, 23.7% delayed presentation. Mean time of onset of symptoms following surgery is 13.46 days. Mean interval from symptom onset to treatment is 4.42 days. Diminution of vision is seen in 100%, pain seen in 65.8%, lid edema is seen in 52.6%, hypopyon is seen in 78.9%, severe vitritis is seen in 89.5%, wound dehiscence is seen in 28.9%, PC rent is seen in 7.89%. In vitreous tap, Staphylococcus epidermidis was the most common isolated organism. In intervention, out of 38 patients, 15 eyes received only intravitreal antibiotics, 23 eyes received vitrectomy and intravitreal antibiotics. Out of 38, 26 patients had poor visual outcome, 12 patients showed borderline visual outcome. Discussion, out of 38 cases of postoperative endophthalmitis in the study, 4 were from institution, 34 cases were referred from other hospitals. Here, endophthalmitis was more common in SICS surgery, followed by phacoemulsification. Mode of presentation, acute onset 76.3%, delayed onset 23.7%, diabetes and severe vitritis were statistically significant in the study. In this study, 89.5% of eyes with severe vitritis showed poor outcome compared to the group of mild to moderate vitritis. Infected eyes that received IV antibiotics alone showed borderline outcome compared to the eyes received vitrectomy and intravitreal antibiotics. Study correlates with the study done by Peng et al. And Kung et al., which is a retrospective study of 82 patients for 11 months, concluded that better outcome was seen in cataract group compared to other prior surgical techniques. Limitations in the study is small sample size in prior intravitreal injection, prior TKP and prior DC groups. Factors
You have
will...
exceeded your time limit almost 2 minutes already. 5 minutes is your presentation.
Yes, ma'am. Factors related to poor visual outcome in the study were diabetes, longer the interval between initiation of symptoms and treatment, delayed presentation, poor baseline vision, corneal involvement, PC rent with vitreous loss, dense vitritis, wound dehiscence, culture positivity, cystoid macular edema. My references. Thank you.
Did you use silicone oil in any of the surgeries?
Yes, sir. Retinal detachment was happened in 3 cases, sir.
So what was the final implications? You mean to say 89% had poor visual outcome?
Yes, sir. There are multiple factors were involved. Majority of the presented with baseline vision. As it is tertiary center, the presentation was late.
So have you made the systematically analyzed it according to the days of presentation?
Yes, sir.
Versus this thing, and what was your observation on that?
Majority of patients were presented after 2 weeks, sir.
So that's why the visual prognosis was so
Was poor.
So thank you all the presenters. We'll
Thank
wind
you,
up the session. Thank you. And thank you all my co-chairpersons. Who is that?
Good evening, everyone. Today I am presenting a case report of a rare case of bilateral multifocal CSR with bilateral bullous exudative retinal detachment. There is no financial disclosures. Introduction. Central serous chorioretinopathy is an idiopathic retinal disorder characterized by localized serous detachment of neurosensory retina and focal serous pigment epithelial detachment within the posterior pole. CSR is typically unilateral, affects young or middle-aged male with risk factor including type A personality, high stress lifestyle, high level of steroid use, obstructive sleep apnea. Multifocal CSR is characterized by multiple focal leaks. Bullous CSR, on the other hand, is a rare and atypical presentation characterized by bullous exudative retinal detachment, which especially involves the inferior quadrant. Case report. A 40-year-old female patient presented with complaint of painless, gradually progressive diminution of vision in both eyes since 8 months. She has completed her family. Best corrected visual acuity was 6/36 in right eye and 6/24 in left eye. Slit lamp examination, intraocular pressure, ocular motility were unremarkable. This is the fundus photo of the right and left eye. In fundus show the bilateral multiple subretinal yellowish lesion with pockets of subretinal fluid and bullous retinal detachment in inferior fundus. Subretinal fibrosis is present in right eye, temporal and inferior to fovea, in left eye, infranasal to the disc. This is the OCT of the right and left eye. OCT shows the inner and outer retinal fold, intraretinal and subretinal fluid involving fovea in both eye. Right eye also shows serous PED, subretinal fibrin membrane, subretinal scarring. Fundus fluorescence angiography. This is the fundus photo. This is the FFA of the right eye, which shows the multiple pinpoint hyperfluorescence in the early phase corresponding to the sites of the leakage. It also shows the blocked hyperfluorescence corresponding to the area of subretinal fibrosis, and there is the hypofluorescent area in the inferior fundus. This is the fundus photo of the left eye, which also shows the multiple pinpoint hyperfluorescence corresponding to the area of multiple leakage points, and there is the blocked hyperfluorescence corresponding to the subretinal scarring is also present. Discussion. A provisional diagnosis of bilateral multifocal CSR with bilateral bullous exudative retinal detachment was made. CSR is typically unilateral, affects young or middle-aged male with risk factor including type A personality, high stress lifestyle, high level of study, obstructive sleep apnea. However, multifocus CSR is a rare and atypical form of CSR which has more bilateral prediction compared to typical CSR. In my case, CSR is bilateral. Patient is young female with no history of steroid intake. Pathogenesis of bullous CSR is not fully understood. However, it is postulated as choroid vessel hyperpermeability allowed fluid accumulation in the choroid which causes RPE decompensation followed by PD and leakage of fibrin in subretinal space causing a retinal tear and exudative retinal detachment. Accurate diagnosis of bullous CSR is very important to distinguish it from the other pathologies such as uveal effusion, metastatic carcinoma or lymphoma, multifocal choroiditis, asympathetic ophthalmia, Harada disease. To avoid unnecessary investigation, inappropriate corticosteroid treatments which may further increase severity of disease could hamper long-term visual outcome. Treatment of multifocal bullous CSR is challenging due to its chronicity and multiple leakage sites. Efficacy of treatment and long-term visual outcome depends on the time of diagnosis. Multiple treatment options exist to treat CSR. In my patient, focal laser was avoided in view of multiple leakage spots in both eye. Micropulse and laser and PDT was not available at our center. Therefore, patient was started on oral epinephrine 25 milligram per day and planned for anti-VEGF injection in the right eye. She was also consulted regarding surgery for subretinal fluid drainage in the case of not significant resolution of bullous RD. To conclude, multifocal bullous CSR is a rare manifestation of CSR with chronic cause of illness. Early diagnosis and intervention is necessary for maximum visual improvement and to prevent subretinal fibrosis. These are my references. Thank you.
Thank you, Vinay. For paucity of time, we are not going to discussion. So we'll end the session. So thank you. We'll conclude the session.
Second session, convener हो. दूसरा session लग रहा है